Thanks for being here for our third of the panel series. And today we're going to be specifically talking about engineering solutions for the next pandemic, exploring ethics concerns. We will keep you on mute until we are going to open for Q&A and comments. Today's panel specifically looks at questions of justice and equity in the COVID pandemic. I'm going to stop sharing my screen for a moment and introduce you to today's panelists and to welcome everyone. The demands of the Civil War, which broke out in 1861, were conducive to the formation of a scientific consulting body to advise our nation. To meet the government's urgent need for an independent advisor on scientific matters, President Lincoln signed a congressional charter forming the National Academy of Sciences in 1863. Under the same charter, the Academy eventually expanded to include the National Academy of Engineering and the National Academy of Medicine. This OEC panel explores the role of today's scientists and engineers in helping our nation to address its current urgencies, such as the coronavirus. Racial and social economic dynamics have become a salient node of ethical concern in our collective response to the pandemic so far. How do you see this being manifested in the United States and beyond? Could engineers have seen this coming? Do engineers have a role to play in avoiding the stark social and racial disparities of pandemics such as COVID-19 infections? In anticipation of inevitable future pandemics, what kinds of engineering solutions might be brought to bear to address and prevent these kinds of occurrences and the associated injustices for Black, Latino, and Original peoples of the Americas? To discuss these and other questions, we are joined today by Dr. Paloma Beamer, Associate Professor, College of Public Health, Chemical and Environmental Engineering at the University of Arizona. Thank you for being with us, Dr. Beamer. Dr. Coletta Chief, Associate Professor and Extension Specialist, Department of Environmental Science, University of Arizona, Tucson. Thank you. I think we're waiting. We're joined, thank you, by Dr. Cato Lorenzen, a member of the National Academy of Engineering and the National Academy of Medicine, University Professor Albert and Wilda Van Dusen, Distinguished Professor of Orthopedic Surgery, University of Connecticut, Director, the Raymond and Beverly Sackler Center for Biomedical, Biological, Physical, and Engineering Sciences, Chief Executive Officer of the Connecticut Convergent Institute for Translation in Regenerative Engineering. Grateful to have you. Thank you. Dr. Lisa M. Lee, Associate Vice President for Scholarly Integrity and Research Compliance, Research Professor, Department of Population Health Sciences, Virginia Tech, formerly Inaugural Chief of Bioethics for the Walter Reed Army Institute of Research, and Executive Director of the U.S. Presidential Bioethics Commission. Thank you for being here. And Dr. Monica Peak, Associate Professor of Medicine, Section of General Internal Medicine, Director of Research, McLean Center for Clinical Medical Ethics, Associate Director, Chicago Center for Diabetes, Diabetes Translational Research, University of Chicago. My heartfelt thanks to each of you for your time and efforts to engage this important subject with us today. And welcome to all of those who are here as attendees. We will begin with an opening statement from each of our panelists, followed by conversation among them. And then for the last half hour, our attendees will be invited to make comments and pose questions to the panel. Until that time, again, all will remain on mute other than the panelists. So let's see where we're going to start. We will go by alphabetical and ask for Dr. Paloma Beamer to begin, please. Thank you.
Thank you for the kind introduction and for having me here today. I should say one of my other hats that I currently serve is as president of the International Society of Exposure Science. And so I've dedicated, although I'm trained as an engineer, I've really dedicated my life to thinking about how we're exposed and how to reduce those exposures, and particularly amongst vulnerable populations. So this topic is of real interest to mine. And as I reflected on the talk here today and what I felt passionate about sharing with all of you, I ended up going back to a quote that I had included in my dissertation, but I think I first came across it as actually a teenager before I even went to engineering school. But it really, you know, growing up as bicultural and binational, going back and forth between my grandmother's homes in Mexico and here in the US, and witnessing disparities for as long as I can remember, I was very committed to wanting to understand why those occur and what we can do to reduce those. And this is a quote from Cesar Chavez, where he talks about how farm workers are society's canaries. And here he was talking about pesticide exposures, but today on the front page of the New York Times, there's an article about how Latinx workers have among the highest rates of coronavirus exposures and cases in the country, in part because they are our front lines. And they are still out there picking our fruit and vegetables every day. We've all seen the meatpacking plant issues, and they have a higher proportion of them that are among the essential workers. This is what motivated me into entering environmental engineering as my training area. And like any engineer, I like to think of things in terms of flowcharts, and often in the College of Public Health, these are not as accepted as when I'm speaking to an engineering audience. But here, if you think about environmental health or exposures to whether it's a virus like coronavirus or a pesticide, we're talking about a source leading to an exposure and then leading to health effects. And this exposure is really, you know, related, is what I think differentiates us from the epidemiologists who are really focused on studying this exposure to health effects part of the equation. Those of us in exposure science think a lot about how people are exposed. And this is, I don't know why it's not letting me go forward. I'm sorry. Oh, here we go. So there's a lot of things that might increase our exposure. And obviously with coronavirus, we're thinking about proximity to infected people, our occupations, essential workers, congregate living facilities, and also our susceptibility that might increase the severity of the disease that we're seeing in our communities that might relate to health status, nutritional status, our age, gender, but we're seeing increasing amounts on the intersection of environmental contamination, which is important here today as I'm speaking to you from Tucson that has a wildfire just a few miles from my house. But we know that all of these attributes are also related to our ethnicity and race and our socioeconomic class. So we need to think about all these complex interactions as we're thinking as engineers on how to reduce exposure. Because until there's a treatment or a vaccine, we really need to be focused on prevention, which is, I think, where my field of exposure science comes in as we think about where we could prevent exposure by controlling at the source, you know, the infected person, along the pathway, whether it's through droplets, aerosols, or fomites, and then at the individual. And one of the things that we teach in occupational health is this hierarchy of controls, which is part of the OSHA guidance, where we want to think about controls that stop at the source as much as possible and increasing, and that will affect the most number of people and reducing our reliance on personal protective equipment or administrative controls at the bottom, because that requires the most behavior change in individuals. So I've thought about, you know, how this applies to some of the controls we're seeing in the pandemic and how they might apply to some of the things we're all recommending. But engineers, I think, have a role in thinking about each one of these and how to design controls that could be increasingly helpful to our communities, and also thinking about what might be most impactful in each of the different communities that I know all of us here today are concerned with. As we talk to you today from Arizona, our cases are amongst the highest they've ever been. They seem to be rising, increasing. So we need to be thinking more and more about each of these steps as we think to how we're going to reduce exposures and transmission in our communities here. And just going back to that slide from the beginning, thinking about how those controls relate to each of these other complex, multifaceted factors and what we can do to engineer solutions that will help reduce some of these injustices that we've been witnessing in the pandemic. And with that, I'll stop.
Thank you. Thank you. And we will proceed then to Dr. Carlotta Chief.
Yeah, good afternoon. Torachi nin shledo to hana bashishin as a lana dashiche do tachini a dashinala akota sanishle. I am coming from the University of Arizona in Tucson, which is on the indigenous homelands of the Pasco Yaqui and the Tohono O'odham nations. I myself am Dene from the Navajo Nation. And the work that I do as a hydrologist is to work towards achieving the land grant mission of the University of Arizona to bridge science to the communities. And the communities that I work with are tribal communities. And using community-based approaches to work to bring scientists, indigenous peoples together to address a real world problem that they are facing. And in my case, those are the environmental challenges and directly linked to health. I would like to share some slides, and I am part of a program on campus called the Indigenous Food, Energy, Water Security and Sovereignty. And during this pandemic, it has even more amplified the need to look at engineered solutions to address these insecurities. This is funded by the National Science Foundation. And so we've been working with the Net College on the Navajo Nation, which is the oldest tribal college in the United States. And in collaboration with them, our students have worked to design a solar-powered water filtration system connected to a greenhouse unit. And the off-grid nanofiltration system provides 50 gallons of clean water to about 30 Navajo families per day. And it's a pilot system that currently is at Diné College. So using traditional Diné culture and knowledge, we have been using this to guide the process in this design process. And the goal is that not only are we teaching our graduate students how to confront food, energy, water challenges with indigenous communities, but that our students would have a cultural understanding to appropriately work with indigenous peoples. This is the nanofiltration system, and it really provides a unit that could be off-grid, and many of the Navajo peoples live off the central infrastructure. And so that is preventing them to have access to food, energy, water. So we work with the Net College to train their students and so that they could also contribute to the workforce. COVID-19 cases on tribal lands are 4 times the rate of the United States average. And so the comorbidities like diabetes and chronic lung disease, kidney disease and heart disease have been correlated to COVID-19 cases in the United States. And we know that these rates are disproportionately higher among Native Americans compared to the US. For example, Native Americans have the highest rate of diabetes in the US. 1 in 4 Native Americans are more likely to have food insecurity compared to the US. And then they also have higher rates of lack of access to clean water. And so all of these combine increase the health disparities that Native Americans face, especially during a pandemic like now. And on the Navajo Nation, which is the second largest federally recognized tribe in the US, there's been a high incidence of COVID-19 per capita. And the Navajo Nation has already had a history of extensive environmental impacts related to uranium mining that has increased their exposure and potentially is contributing to the risks for them to have morbidities and infection to COVID-19. So majority of the people on Navajo Nation also don't have access to energy. So they're burning wood and coal. And so that creates indoor pollution. And as we know, with COVID-19, respiratory issues is a huge part of COVID-19. On the Navajo Nation, they also only have 13 grocery stores. So thinking about, a land base the size of West Virginia, which is like 27,000 square miles, a vast rugged terrain, and you only have 13 grocery stores. In a recent report, the president of the Navajo Nation, Jonathan Nez, also said that multi-generational homes could also be a contributing factor where the family members are unable to self-isolate. And so all of these fused insecurities are even more amplified during this COVID-19 pandemic. And so the work that we're trying to do at the University of Arizona is that we're trying to teach our students to be better engineers, better scientists, where they're solving these real world challenges that in a way that they're considering the indigenous communities and their culture, their ways of knowing, and their own problem solving approaches, rather than just doing helicopter research or just designing solutions that are dropped in the community and are not inherited by the people. So we bring our students to the Navajo Nation where they're immersed in the culture, they're teaching at the Diné College, they're engaging in co-design. So I look forward to this conversation with my esteemed panelists. This is just a brief summary of the health disparities occurring on and in indigenous communities, specifically the Navajo Nation, and how that's been amplified by not only historical trauma with the federal government's assimilation programs and other historical trauma activities, but now with the COVID-19 pandemic, even more amplified these risks. So I look forward to discussion with my panelists moving forward. Thank you, Ahihet.
Thank you, Dr.
Great. Thank you so much for having me and for including me in this wonderful panel. We had no idea what each other was going to say. And so I didn't prepare slides, and I'm actually kind of thankful that I didn't. I just have some notes. And so what I'll try and do is make some comments that haven't been made already. I think we've already had a lot of wonderful discussion, and so I'll try not to be redundant and just sort of hit a few other highlights. I may impose upon what Dr. Lee is going to say, because I'm going to have a few things around ethics, but all right, so one of the things I wanted to underscore is that we have both with marginalized populations, the individual risk and the place-based risk. And so structural inequities based on race or structural racism affects where people live in their communities, as well as the individuals themselves. And both of those put people at increased risk for COVID exposure and prevalence and mortality. And so we have to think about both of those when we're trying to mitigate disparities. And so, for example, when we're thinking about place-based risk, that is the consequence of redlining, residential segregation, all those policies that were put in play years ago that still exist today, where we have a lot of racially segregated neighborhoods that persist. I'm in Chicago, where we still have communities that are largely divided by race and class. Most of our communities still are more than 95% of one of the three major racial ethnic groups that are in the city. We're 1/3 Black, 1/3 Latinx, and 1/3 white. And there are just a handful of those communities. Hyde Park, where I live and work, is one of those that's a mixed community, the rest of which are very segregated by race and class. And so, and those lines were drawn decades ago. And so in those communities that are predominantly Black and brown, you'll see just all the stars align for what you'd expect to be extra vulnerability to things like a pandemic. So housing that's overcrowded, people living in multi-generational housing, very low social distancing scores, extra pollution and toxins, people that are the higher percentage of people that are unemployed and those who are working as essential workers, higher rates of chronic diseases, lower rates of health insurance. And so you have entire geographic communities that are at risk. So if people come in who have coronavirus, there's an increased likelihood that that will spread in that community because of the increased risk. Then you have the chronic effects, no matter where you live. I'd say that, all African Americans don't live in Black communities that are 95%, but we're still nonetheless, because of the allostatic load, because of the disproportional impact of racism, affected by that and put at increased risk. So that no matter where we live, we are affected by the limitations of opportunity as far as education, housing, increased exposure to police violence and incarceration, all of those things that work at the individual level to limit our opportunities in life and put us at more likely to be in lower wage jobs, to be essential workers, et cetera. And so we have to think not only about mitigation strategies that work at the individuals, but also at communities. And there was a study that in addition to the sort of county level study that was referred to earlier, that was looking at county level associations between Blackness and COVID. There's a study that recently came out from UCSF that looked at a neighborhood. Many of you are probably aware of that. And the neighborhood was in the Mission District, where there's a mixture of whites and Latinx persons. And even in the same building, those who were Latinx were more likely to have COVID because they were living in a single apartment that may have had 8 people in it. And the people who were living there had to go out and work in essential services, whereas they may have a neighbor who was white and had the ability to work from home remotely. And so even in the same neighborhood, you may have different levels of risk. And so I think there were 30 white people who, I'm getting the numbers wrong, but so I don't want to say them, but the amount of people who were Mexican in that community who had the coronavirus compared to the number of white people who had the coronavirus were starkly different, even in the same geographic area. So we have to think again, not just about we have to think about both of those things when we're thinking about mitigation strategies. The other thing that I want to sort of touch on is the bioethical principles that we can think about when we're trying to get to equity. One of those is fairness. And there's been a lot of conversation about fairness and equity in the distribution of scarce resources, mainly around ventilators, but also just about as we're thinking about medications, remdesivir, other things as they're coming down the pike. And we typically have been thinking about it as to each an equal share or a lottery system. But fairness also can be defined as to each according to need. And I think that's probably a more appropriate definition of fairness because we have entire populations that have an increased need for resources based on their historical and contemporary either medical need, the needs based on their built-in social environment, other things that put them at increased risk for poor health outcomes. And so I think that in thinking about allocation, that we have to think more to get to equity. We can't assume that everyone is starting from a level playing field. And there's some who are, some hospitals that are starting to use things like the neighborhood deprivation index at the personal level. So if someone comes in and is coming from a zip code that has deprivation indexes that are particularly bad, then that person would have those numbers that are part of the calculated risk score for whether or not they might get a scarce resource or not. And I think that's a way of trying to increase equity when we're thinking about how these scarce resources are being allocated. The other is that sort of extends this principle a little further is distributive justice. And so that's one that takes this concept a little further and says that not only should we be distributing resources to those who are the most vulnerable or who have the least among us in society, it's the reason that we should be doing that is because their position in society is there because of society that we have placed, that we have intentionally marginalized some populations because of the policies, procedures, and the way that we do business in our, as part of our comings and goings and the ways that we run our social norms. And because of those, there are some that become the haves and the have-nots. Because the have-nots are there disproportionately because of our rules, then then behooves us in these certain times of crises to give those persons more resources, to redistribute them in a way that tries to purposely bring about equity. So it's not only because they're more needy, it's because the cause of their increased need was our fault, essentially. So distributive justice is another bioethical principle that we can use to think about how we're going to get to equity in times of this coronavirus pandemic. And the third is one of reciprocity. And so that is for people who have been putting themselves at increased risk during the pandemic, that they have extra protection. So we normally think about that. I think everyone's in common agreement for that. We think about physicians on the front line and other healthcare workers that are on the front line. We have not necessarily extended that concept to all people who are working in the hospital. So the people that are making sure that the rooms are clean when we turn over, the people that are providing food for people in the hospital, everyone who is working in the hospital is on the front line. And so we should be expanding how we think about frontline workers. But obviously that also expands to essential workers. They have allowed the rest of the country to be safe. They're the ones who have disproportionately shouldered the burden to allow us to flatten that curve. We have been allowed to stay at home and have our groceries delivered, or telework, so that we knew that our electricity was on, and all these other things that allowed us to comfortably and safely shelter in place because other people were picking our fruit and making it available in the grocery store, delivering our mail, making sure that we could be online. And those people have, just like healthcare workers, put themselves at increased risk. But unlike healthcare workers or physician healthcare workers, they have not been adequately protected. And so it's the bioethical principle of reciprocity that we can also use to get towards equity, because those essential workers have not been necessarily treated as essential. And so I think those three principles are ones that we can try and lift up as we're trying to make our way towards equity. As a physician, I would also just add that as we're thinking about tangible strategies, that we think also about the integration of medical and social needs. Not just at the healthcare system level, but that's important, that we have, as healthcare institutions, before the pandemic set in, begun thinking more about, housing insecurity, food insecurity, and how, particularly those two, how they were directly related to people's health. And trying to think of how to make those connections between healthcare systems and non-healthcare systems for our patients with chronic diseases to improve their health outcomes. I think this pandemic has highlighted the importance of doing so, not only within healthcare systems, but also outside of our healthcare system, so that for people who don't have chronic diseases, we still need to be able to think about engineering systems in place for people who may be in need in times of a pandemic. So our previous speaker was making allusion to those kinds of things, that we need to be able to have our food systems, our hotel industries, our other kinds of housing systems be able to work in synchrony to better able ourselves, in addition to our healthcare systems, to provide adequate services and places for us to be able to have safe spaces for people who have the coronavirus to shelter in place, because they cannot return from the hospital to overcrowded homes where there are 15 other people sharing the same bathroom. That is not going to be good for that family or for the public's health, or particularly for the communities in which they live. And so we have to think about this from a population health and a public health perspective. And that is partly an engineering issue for us to be thinking about how we're going to structurally address the built environment that we have forced low-income communities to live in, but that will directly impact the rest of our nation. And so I'll pause, I'll stop here because I have lots more I could say, but I do want to hear from our other panelists and then open it up for discussion. Thank you for having me.
And thank you, Dr. Peak. Dr. Lee, please.
Thank you, Dr. Byrne. It's really an honor to be here. As an epidemiologist and a public health ethicist, I come to this from a population health perspective, recognizing the multiple and often unseen distal determinants of health, those powerful structural forces that shape health outcomes. Vulnerable communities have suffered staggering losses in health, education, and economic well-being as a result of this virus. These losses are greatest for low-income communities, in large part due to baseline disparities, about which we've heard already, that exist in each of these areas. Low-income rural residents are especially vulnerable due to the numerous infrastructure disadvantages that they face due to geography. During a disaster, social and medical vulnerabilities are amplified, and they produce synergistic disparities, that is, disparities that together are worse than the sum of their parts. COVID-19 has had a dire impact on health, education, and economic lives of vulnerable people, and these impacts in turn will have dire consequences for their future health, education, and economic lives. So I want to talk first about health impacts. The disparate health impacts on vulnerable communities were as predictable as they are disturbing. We've known for centuries that there's a strong relationship between low income and poor health outcomes. More recent data, of course, have shown the degree of income inequality further and independently assaults the health of people living on the low end of the income scale. Poor men die, for example, 15 years earlier than men in the top income tier, and that difference is about 10 years for women. Poor communities and communities of color are also often targeted for advertising by alcohol, tobacco, and food industries. And rural communities are easy targets for environmental injustices that affect health. And together, these factors increase the risk of chronic conditions such as asthma, heart disease, diabetes, and these comorbidities then substantially increase the risk for death from COVID-19. Next, the disparate educational impacts. So these are a little bit more pernicious, but they do not bode well for a strong economic recovery from COVID-19. Unlike health disparities, pre-existing educational disparities in the US are well documented. We know, for example, that each year predominantly white school districts receive about $23 billion more than predominantly non-white districts. That is $2,000 less per student. And with the sudden pivot to online instruction, COVID-19 is exacerbating these deep inequities. For example, online learning requires internet access. A 2019 study found that in predominantly white rural counties, about 75% of residents had access to broadband internet, while in predominantly Black rural counties, only 56%, that's 20 percentage points lower, of residents had access. Now that means that 44% of Black students in these, well, of students in general in these rural counties cannot do school online. And for Native American communities, as we've heard, COVID-19 has hit very hard. Just 25% have broadband access. Learning loss is also a major concern. From other disasters such as Hurricane Katrina, we know that students fall behind or worse, never return following disasters. These losses also affect disadvantaged students more drastically than their privileged peers. Former Secretary of Education, Dr. John King, recently summarized the racial disparities in learning loss after disasters. 7 months for white children, 9 months for Latinx children, and 10 months, a full school year equivalent for Black children. Now, this disparity is again related to the structural and funding disparities that have existed in schools forever. Finally, the economic impacts. The disparate economic impact on vulnerable communities is likely to be with us for years. White collar workers, 80% of whom are white, have been the least affected economically by this pandemic. They're much more likely than service or trade workers to be able to work from home and to maintain their higher incomes. Only 1 in 5 Black workers and 1 in 6 Latinx workers can work from home during this pandemic. Many of them who cannot work from home have lost their jobs. So those who have not lost their incomes already face a very difficult choice of continuing to go to work, often in industries deemed essential, such as meat processing plants, industries that continue to suffer from a shortage of PPE, a lack of sick leave, and the inability to physically distance their workers. These jobs, while they provide essential, albeit low income, put workers and their families at extremely high risk for COVID-19. So on their own, each of these vulnerabilities is devastating in the face of the pandemic. Together, they create a synergy of vulnerability that will have lasting consequences for hundreds of millions of people in our country. So where is the hope? Well, I'll say that public health professionals, like engineers, are problem solvers, and problem solvers are generally optimistic by nature. And optimism is what really pushes us in our fields to act. I hope that our conversation today will spur all of us to action, and that together we'll engage in this massive problem-solving effort to build equity into the structural forces that shape the health of our most vulnerable communities. And I really look forward to the conversation.
My goodness, thank you so much. And we have laid the groundwork for a really important conversation with our attendees. And at this point, I think because we are now almost to the top of the hour, it would be a good time to include them. Thank you all. And let's proceed to include our attendees. There's Kyle Ferguson. If you're with us, I'm happy to have you ask your question directly with your microphone.
Hello.
Hi.
Hi, thank you very much. This was wonderful. My question is about allocating scarce critical care resources. I've heard that some have proposed assigning points to patients based on their membership to historically marginalized communities, as Dr. Peak alluded to. I was wondering what the panelists thought about this proposal and whether such an allocation scheme would be fair or just, even if it meant that fewer lives total would be saved.
Is the question clear for panelists? What's being asked?
Well, let me just start. I think that number one, I think that the way in which we've thought about and we allocate care in terms of COVID-19 at this point is, is wrong on so many different levels. Number one is that it focuses on the hospital where you're supposed to come when you're really sick, instead of this is a disease that you actually want to intercept the person and provide them care before they're very, very sick. And so even in terms of allocation of resources, the allocation of resources should take place way before the person actually gets to the point where they come to a hospital. So that's one. But I do believe that we should be looking at community resource allocation only because of the fact that in terms of our environment of systemic racism, even if you try to make it fair across the board, not even especially assigning extra points to a different group, if you just try to make it fair across the board, you'll have some meaningful change. The other point, of course, is that there's a very important paper that was just published this week in Science magazine that has uncovered that an algorithm that's used by one of the major companies, Optum, for looking at for making clinical decisions and providing clinical resources for patients has been racially biased. And one of their and the algorithm, in terms of looking at who's sicker and who needs the most care, actually had a factor factored in that said how much money is being spent on that patient, and the more money is being spent on that patient, the sicker, as a surrogate for how sick the person was. When in fact, Black patients often are not, given the resources, and are not actually provided that money, as much money in terms of dollars of care. And so they were then double hit with getting clinical care algorithms that actually provided them less care based upon the fact that they were being provided cheaper care to start out with. And so we also have to be very, very careful about clinical algorithms in terms of how they're used, because they can be used in a way that actually it goes against promoting racial and ethnic justice.
And let me just clarify. What I'm saying is that we should rely on bioethical and public health principles. And so if we know that there are communities that have higher prevalence and higher rates of mortality from a disease, then those are the communities that we should align our resources in, right? And so those communities that we know of right now are ones that have historically been marginalized, that don't have the same access to resources, that if we just look at the communities themselves are sort of set up for pandemic spread within those communities. And so race itself is a marker. There's nothing about brown skin that makes you more likely to have COVID. It's that your brown skin is a marker for being exposed to racism and all of the things that come with racism. And so that you're more likely to get the disease because of the social circumstances. And so we should be directing our resources towards populations that are more likely to have the disease. It just so happens that those populations are Black and brown. And those populations right now, it may be because of the way that the states have been reopening, we're seeing surges in certain in certain states. Those states are going to need to have a reallocation of resources. So I think we should be following our epidemiological information. But in this case, right now, historically, what we have seen is that the numbers have tracked along with race and ethnicity. So in my city, where we have 30% African Americans, 70% of the deaths were from Black people when the numbers first started hitting. And so that meant that we had to have an aggressive strategy to figure out why that was and how to bring those numbers down. And so that's what I'm saying.
I can also respond to a part of that question, and in terms of allocation of resources. On the Navajo Nation, 40% of the tribal members lack access to water. So here we are in 2020 in the United States of America, and we have thousands of tribal members who can't even wash their hands for 20 seconds. They're using 5 to 20 gallons per day of water. They're conserving what water they do have access to. And so there's a great need that has existed prior to this pandemic, that there's citizens in the United States that don't even have access to clean water. And we're not in a third world country here, we're in the United States. So in that sense, I think, yes, there needs to be reallocation of resources to address lack of access to clean water in tribal communities. It's far too long, too much time has passed, and this has not been resolved. In addition, the healthcare system in tribal communities is based on the Indian Health Service, which is under-resourced, underfunded by the federal government. So right now on the Navajo Nation, with these high rates of cases per capita, they're not able to care for those very sick patients in the Indian Health Service. They have to be flown to cities hundreds of miles away. These are 2 to 3 5-hour flights for these critically ill patients to have to be flown to Phoenix, Arizona, or Salt Lake City, Utah, or Albuquerque, New Mexico. And so there does need to be a reallocation of resources to provide good health care to the First Nations citizens of the United States.
I wanted to chime in too, and thank you both Dr. Chief and Dr. Peak for your comments. Having spent time with Dr. Chief on the Navajo Nation, I think it's incredibly important to acknowledge the lack of water. And then going back to Dr. Peak's comments on bioethical principles, and it reminds me of also the concept of participative justice and who's making these decisions right now that are affecting all these communities, and who's at the table to make those decisions and to participate in that resource allocation and the policies that are being employed. And I think that's one of the things we need to look at too, as these states are reopening, like our state here in Arizona that has among the highest per capita rates of anywhere in the country right now. That we have policies being made by people who get to stay at home, work from home, who don't live in these communities, who have access to clean water, electricity, medical facilities, and aren't from the communities that are being impacted most by the pandemic. And so we need to think about how to bring all of our voices. And I want to just acknowledge you and thank you for this panel today, where we had a chance to talk about these issues on a national level, but how do we get our voices heard with those policymakers in our state? It's our governor, it's our director of health services. They're making decisions not to close down bars, not to do things. We're completely open, our restaurants are open, and communities that have the privilege to choose to go out and when they can are choosing to enjoy that. But it's at the expense of those who are not at the table, who are not able to participate in those discussions. that are on the front lines, that are picking our foods and vegetables, that are working in our grocery stores, that are bringing our packages to our homes. And so how do we change that participative justice too? I think that's another thing we need to think about. So those who are experiencing the brunt of it are involved in the decision making.
All right, so I want to say thank you, Kyle Ferguson, for what turned out to be a provocative and really important question. And there are two more. We may be able to get to both. We'll see. Jean Kraft, would you like to come off mute and pose your question to the panel?
Sure. My question has to do with some of the struggles that we've seen in New Jersey. We are, I think, 48th in terms of among the states in terms of Medicaid reimbursement. And so a lot of the practices that have a high percentage of, I'm a pediatrician, but kids that are covered by Medicaid or by the CHIP program are operating on a shoestring. And one of the struggles they found is that when they are competing against large healthcare systems, against practices that have a private insurance, perhaps a better buffer, they really were not able to compete for the personal protective equipment. They were priced out of the market. And so, you know, if the offices that are serving people who need help can't get the supplies to protect the patients that they're serving and to protect themselves so that they continue, you know, I think it speaks to the, you know, a fair distribution is not necessarily one for each. It's, you know, based on who has a great need. And it wasn't until the third federal package of dollars to practices that Medicaid was even considered. It was all Medicare based. So it really was pricing out, you know, what were considered the undeserving poor when Medicaid was added as a poison pill to the Medicare bill to try to kill it. You know, there was an assumption that if you're poor, it's your own fault, and that Medicaid is insurance for people who deserve to be where they are. And, you know, I think that is just perpetuates the disparate medical care.
If I could ask one of you to respond to that, and then we'll have time for the last question. I think that would be a good way to proceed. Thank you. Whoever's comfortable.
I can take it, but
Please.
I've already spoken. I mean,
Please do, Dr. Peak, please.
okay. I think it's the responsibility of academic medical centers and other large tertiary hospitals to use their economic strength and their bandwidth to lean in to smaller community hospitals, to clinics, and to others with their resources during this pandemic. It's their ethical obligation. And to community-based organizations. We have the resources and the infrastructure to provide care for, we're set up to take care of people in times of a pandemic. And so we have, you know, the fanciest testing, we have all of the PPE, and we can't just hoard that. It's our ethical responsibility to share that with everyone else. And so at the University of Chicago, we have been, because we understand that we are all in this together. And if our community clinics don't have the equipment that they need, then these hot spots, we're sitting right here on the south side of Chicago, are going to rise up, and they will end right back up ultimately in our hospital system. So for selfish reasons, if we can't do it for the right reasons, we should at least be doing it for the selfish reasons, you know? And so obviously we should be doing it for the right reasons. But it's short-sighted for an institution to hog all the stuff in the basement, like people were hoarding toilet tissue, and not let others who need the resources have access to them. What affects one affects everyone else. That's the lesson that we all have learned from this pandemic. Yes. And I think we have to call upon all of our academic institutions, all of our tertiary hospitals, to not only take patients regardless of ability to pay, but to share our resources with our less resourced neighbors.
Thank you. Thank you so much. I feel like we're just starting, and yet here we are at the end. Let's see if we can make time for Alana's Dabas question. I think to Dr. Lorenzen, you were posing a question. Please, feel free.
Yes. Touched upon this as well. There's a lot of existing technology and existing solutions that could be used to address some of this equity, but are not. My question is, how can engineers, and what role might engineers play in helping decision makers utilize these technologies?
Can we get a very brief answer? Please, Dr. Lorenzen.
Well, it's not super brief, but it's semi-brief. So it's about 3 parts. The first part is that we as engineers have to do a better job of really talking about engineering and making it a big area. You know, in other countries, there's Engineers Day. We don't have an Engineers Day in the U.S. And so our politicians actually don't understand a lot in terms of what we do and what we're about, because we're sort of invisible. The second is that we need to be more visible in terms of communities. There's a Doctors Day where doctors go and see kids in high schools and grade schools. Very few Engineers Day where engineers are going to talk about what they're doing. And so in order for us to be heard, we've got to have a presence that's there. And the third is that we have to be able to, do what we do. We have to invent. So I gave a engineered equity example, and that engineered equity example was we took masks there are tons of masks that are just general surgical masks, and made them more like N95 masks, more N95-like, by creating mask frames that actually created a perfect seal around the face by 3D printing. And that's the kind of technology where we can harness, where we use our inventiveness to take resources that are already out there and to improve them for others. There are tons of regular surgical masks. The N95 masks are very, very expensive, and also at some places they're scarce. But by using regular masks with technology, using the technology, patented technology, I may add, we can find ways to be able to engineer solutions using the conventional things that we have in abundance now.
Well, there we have it, an Engineers Day. I want to say thank you to all of you. This was a partnership with the Association for Practical and Professional Ethics, otherwise known as APPE, along with the Engineering Ethics Division of the American Association of Engineering Education. It could not have happened without funding from the NSF, for which we are quite grateful. I thank all of them and all of you, as well as our attendees, for being part of this really important conversation at a very serious time for our country and the world. Thank you so much. Thank you.